Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. In today's episode, Dr. Anchalee Avihingsanon from Thailand and Dr. Reena Rajasuriar from Malaysia share their thoughts on some of the most important new insights from HIV treatment and prevention research over the past year, specifically in the context of HIV care in the Asia-Pacific region. For more information about our guests and for additional online education on this topic, please visit the link in the show notes. So now, let's turn it over to the faculty.
Hi, Anchalee. How are you?
I'm good, thank you. So how are you?
I'm fine, Anchalee. I understand you just came back from CROI 2023. How was it?
Oh yeah, it was very great. Seattle is very nice, and I think this is the first time in-person meeting. So after we have a COVID-19, so it was such a great meeting. Yeah. Okay. So today we're gonna discuss about the ART in Asia, right? Including the how to take care of all the older people in Asia. Yep. So I think so. Despite in HIV-1 therapeutics, so all our people living with HIV will require HIV treatment for the rest of their lives. It is very important to select the best optimal ART regimen for this population to avoid long-term complications of long-term ART exposure. So in particular, weight gain. So it is a factor that may warrant careful consideration when selecting the appropriate ART regimen in this population. So although weight gain may indicate a positive response to ART in this population, excessive weight gain increase the risk of obesity-associated comorbidities, such as metabolic syndrome, diabetes mellitus, cardiovascular disease, and also they might have advanced problem because of the stigma of the obesity. So several recent studies have reported the greater weight gain and obesity among people living with HIV receiving integrase inhibitor than boosted PI or non-nucleoside reverse transcriptase inhibitor. And also very important that the NRTI, especially tenofovir alafenamide or TAF, is also associated with a greater weight gain, especially if it's used with dolutegravir. That for both ARV naive or ARV experienced people. So the data from Japan also show that the Asian people living with HIV continue to gain weight after ART with DTG and TAF plus FTC gain the most weight at both 3 and 4 years. So importantly, Asians are likely to have central obesity and insulin resistance than non-Asian at the same BMI. So therefore, the BMI cutoff criteria of obesity in Asian population is usually greater than or equal to 25 kilogram meter square compared to greater than or equal to 30 kilogram per meter square for non-Asia. And very important that approximately 7 to 20% of non-obese HIV uninfected Asians with BMI less than 25 are estimated to have non-alcoholic fatty liver disease. So we call it a lean NAFL or lean NASH. So this condition is associated with metabolic syndrome and various extrahepatic comorbidity, so including cardiovascular disease and cancer. Therefore, the weight gain in Asian population has clinical meaningful. So with the need of for reducing toxicity, improving tolerability, and the cost effectiveness of ART motivation, so the development of 2-drug oral ART regimen, so for example, DTG plus 3TC, so is currently included in recommended ART for both AV naive with HIV viral loss less than 500,000 copy per mil, and for those with stable ART with viral suppression. And also, they are accumulating evidence that the DTG plus 3TC had long-term efficacy and safety, similarly to 3-drug regimen. So another one is a DTG plus ripivirine is also recommended for those with viral suppression for maintenance therapy. And also emergence of long-acting injectable cabotegravir plus ripivirine injection for maintenance therapy. So has also been reported. So there are some scenarios with deserve special attention in Asian people living with HIV. So firstly, two-drug regimen cannot be used with hepatitis B co-infection. The prevalence of Hep B co-infection in our Asian region is quite high. So as 8 to 15% of them have co-infection. Secondly, the DCG plus 3TC is not recommended in people with HIV viral load greater than 500,000 copies per mil. And therefore, it is not appropriate for test and treat and all same-day ART because we need to give the ARV right away. So in addition for that, many Asian countries, I think including Thailand, do not have baseline viral load prior to first-line ART initiation. So we don't know whether the patient have the viral load higher or greater than 5,000 copies per mil or not. And apart from that, the long-acting cabotegravir and ripivirine in Asia, so we need more resource and funding because although this long-acting regimen is good, particularly for those with poor adherence, so because it can be used every 4 weeks or 8 weeks, but the cost, I think the cost is still very expensive for us. And also with the muscular injection, so the burden of healthcare facility is quite high for this. So I think if we talk about the adherence, so everyone might know that our Asian patients, they have a very good adherence because they have a great trust for the physician and have respect to the physician. So I think the adherence should not be a major factor for our Asian population. I think the long-term efficacy and safety of two-drug regimen and also the injectable thing. So we need more long-term data in our Asian population. So, Reena, so I just would like to turn over to you. So as our patient, they are getting older. So do you have any advice or any recommendation to have a better care for this population?
Thanks, Anchalee. I think you raised some really great points with regards to the need for monitoring of long-term complications on heart. And I think this is going to be really our next challenge as we advance HIV care. And this needs to change our focus of how we care for our patients. And this needs to be beyond viral suppression and immunological outcomes. I think in the Asia-Pacific region, we expect about a third of our patients or people living with HIV to be over the age of 50 by 2025, and that's just 2 years away. So we're already seeing individuals with very complex care needs in our HIV consultations. So for these individuals, really, viral suppression and CD4 counts are no longer the issue. They're doing really well with the medications that they have. But what is really challenging now is the chronic comorbidities like hypertension, dyslipidemia, cardiovascular disease, liver disease, as you mentioned previously. And these conditions tend to occur at earlier age in people with HIV. And it's been also recently shown that not only does it occur earlier, it's also associated with greater disability compared with individuals without HIV. So this sort of raises the question of, should we really be employing more enhanced screening and more aggressive management strategies for NCDs and malignant sees in people with HIV. In Asia, I think we tend to rely quite a bit on the guidelines developed for the general population, and this then is applied in the care and management of our people with HIV. Unlike US and Europe, where guidelines tend to be more tailored and more specific for the population. I think we can also expect, with different lifestyle factors, risks for co-infection, and even levels of immune activations which differ regionally, these background factors may contribute differently to the risks of comorbidities, the comorbidity occurrence, as well as progression in people with HIV. And it makes sense that these risks are then taken into account when considering how we screen for NCDs and cancer. But I think chronic comorbidities are not the only issue, actually. Age-associated issues like frailty and cognitive impairment are also a challenge to manage in our community as they grow older and they become more prevalent. Mental health disorders are highly prevalent in the Asia-Pacific region and occur both in young and older individuals. And care for these conditions are particularly challenging for a number of reasons, actually. So first, the fact is that I think HIV care tends to be very siloed in our region, and often HIV care providers are perhaps the only care providers that our people with HIV see for all of their health conditions. So the burden to screen and care for all of these conditions, non-HIV conditions as well, falls on the HIV clinicians who are really not trained in managing them. Secondly, many people with HIV are not very comfortable seeking care outside of the HIV clinic. And this is largely driven by stigma and discrimination. These fears are often valid, as we have recorded quite high rates of stigma and discrimination in many of our healthcare settings in the region. As such, even when issues are detected and they receive a referral to a non-HIV specialty, people with HIV often are highly reluctant to follow through on the referrals. They may attend a few visits and subsequently, just default. So continued care for many of these non-HIV conditions are a real problem. There are some good models of integrated care where non-HIV and HIV providers sit together in the same clinic to see people with HIV and give them more holistic care. Or sometimes these specialties come together with a lot of coordination and streamline. But a lot of these models are really have only been established in high-income settings, and we're yet to see sustainable models of integrated care in low-middle-income settings, including in the Asia-Pacific region. In many of our settings, we don't even have sufficient expertise for areas of geriatric care and mental health, and to even cater to the needs of the general population. So services are very stretched, and there are significant challenges when we try to integrate aged care or mental health care into HIV services, as these are just really not priorities. So there is perhaps a role for dual training where HIV clinicians are trained in basics of geriatric care or mental health care, or even task shifting to non-specialist care providers such as HIV nurses. And this is also a good option, as the initial triage and management can still be done within the HIV clinic. And only when most severe cases are detected, they are referred to specialist care. Talking about the issue of aged care and managing older people with HIV, I think one of the more important things to address as well, apart from medical care, is the community, what happens in the community. We really need to strengthen community networks and support for people with HIV in the Asia-Pacific region. Here, multi-generation living is very common, and it is a norm that older people are usually supported by family and friends as they grow older. However, for many people with HIV, they're often estranged from their family members because of stigma and discrimination. And so they have much smaller social networks that they can rely on as they grow older. So this is where I think NGOs and community-based organizations who really understand the unique issues and challenges of people with HIV can play a huge role. I think a lot of things to think about as we deal and manage with our older population. And you're right, as long as we don't have a cure, this is something that we're going to have to deal with. But hopefully, with advances in prevention, we can stem the growing number of people with HIV. And Anchalee, I wonder whether you can tell us a little bit more about prevention.
Yeah, so thank you. So I think the prevention is better than treatment anyway for all diseases, including HIV. And so in Asia Pacific is a second high HIV burden after the African region. So I think the prevention is very important. For today, I would like to end our discussion on the innovative for HIV PrEP or HIV pre-exposure prophylaxis in our region. So as you know that there's major advance in HIV prevention over the last year has been long-acting injectable cabotegravir for PrEP. So the data that cabotegravir long-acting so demonstrate the superiority to oral TDF-FTC. So with a 66% relative risk reduction among men having sex with men and transgender women in HPTN 083 and 89% relative risk reduction among cisgender women in HPTN 084 study. So the CAP area reduce stigma and improve adherence to HIV PrEP. It is currently included in medicine patent pool, or we call MPP, for almost 90 countries. And also the WHO has endorsed it. However, there are some important issues for consideration in scale up CAP-LA in our region. Firstly, logistic and cost consideration. So I think Thailand and Malaysia are excluded from MPP. So the price of CAP-LA is still very expensive for us. And I think with the intramuscular injection of CAP-LA in the buttocks, which remains a burden in many centers. So for example, any staff time, financial support for the patient to travel to the site, and also logistic, the reorganization of HIV prevention. So the CAP-LA is not appropriate to use in community-led program. So in Thailand, the HIV prevention is run by our community-led program. So if we use the CAP-LA, it cannot be implemented to that. And also with this regimen, I think we need more frequently HIV monitoring. So every 2 months rather than every 3 months. So secondly, the CAP-LA substantially alters the timing and pattern of HIV seroconversion, resulting in delay in HIV diagnosis, delay ART initiation, and also increase the integrase resistance. And also the HIV testing algorithm is also changed. So we need the nucleic acid testing based algorithm. So with this, it's quite expensive, and it could represent a major pitfall in the implementation of the CAP-LA in our region, particularly in low middle income countries. Thirdly, emergence of integrase resistance could be occur for those initiated the CAP-LA undiagnosed acute HIV infection, undiagnosed breakthrough HIV infection despite on-time injection, or breakthrough HIV infection during tail phase. So efficacy of integrase inhibitor in this region could be compromised by this emerging of integrase resistance. Fourth, I think we have to deal with the long duration of tail phase after the last injection. So with a median of 44 weeks for males and 67 weeks for female, this also challenges the CAP-LA for providers and user. And these periods, the cabotegravir drug concentration might be like too low to prevent HIV, but it's sufficient to select integrase resistance. So I think in summary, the implementation of CAP-LAA in Asia is still a huge challenge. It needs more resource, funding, and strong commitment of our stakeholders. So another promising PrEP medication. So I think lenacapavir. So lenacapavir is being studied in a phase 3 clinical trial as a potential PrEP product for MSM and transgender and also cisgender women. So with the subcutaneous injection every 6 months, so making it eligible for self-injection and less burden to healthcare facility. And it might be easier for scale up in community-based facility. So I think we should stay tuned for long-acting lenacapavir efficacy for PrEP. So if it works, it's a game changer in future HIV prevention. So thank you very much.
Thank you, Dr. Avihingsanon and Dr. Rajasuriar, for sharing your insights with us. And thank you for listening. Look out for more episodes in this series at clinicaloptions.com/HIV.